Dr. Yana Etkin, who is a professor in surgery now at Zucker School of Medicine. She's also holds numerous roles at Northwell Health, including the program director for vascular surgery and also with the associate chief of vascular endovascular surgery, along with that for the system chief. She is a rising star in venous and vascular care, and she just came back from a meeting at the SVS in Boston, where she was a chairperson, co-chairperson for the Venous Toolbox 2026. Congratulations. A little bit about the session that you had at the the Venous session at the Vascular Annual Meeting.
So we had an opportunity to put this educational session together with Dr. Nick Mawad. And the idea behind this session was to kind of highlight multiple various venous disease processes that vascular surgeons deal with every day. And then we wanted to highlight that, venous disease is not one disease process, and it cannot be just managed with one algorithm or one device. We manage people with superficial reflux, and then people with iliofemoral obstructions, people with upper extremity DVTs, and pelvic venous disease, and all of them may require different tools. But in real practice, often these conditions overlap, and patient may have a reflux and obstruction, and venous ulcer and lymphedema. So the toolbox concept was meant to say, we need diagnostic and imaging tools. We need to know the guidelines. We need to have wound care tools. We need to know how to do endovascular and open surgical procedures. We need to know what's the right tool for the right patient. And we kind of need to really have this big toolbox to provide comprehensive care for patients with venous disease. And vascular surgeons really should be taking charge of taking care of patients with various venous pathologies. So that was the idea about the session, to sort of highlight what tools we have and how to really provide care for these often complex patients.
You covered quite a few topics between upper lower extremity DVT thrombosis, recurrent varicose veins in females. Um, you have a lot of material here. What did you end up taking away from this whole whole wide spectrum that you covered in venous disease, especially with the current technologies?
So, interesting because I think, I'm a program director for our training program. I'm very involved with education on local, regional, national level. And I think often the venous disease is kind of overlooked in training. If you look at the requirements, of venous disease cases in training is very minimal. And I think a lot of us are lacking that training. When we're in training, we're lacking that knowledge when we go into practice and we start picking up things in practice. And sessions like that, I think, are very important to really learn things. Like I've learned quite a bit in this session. I mean, things that were discussed, like for example, for the management of superficial venous reflex, the jury trial data was discussed, which is really was kind of groundbreaking because traditionally we always thought if people who don't have junctional reflex, even if they have GSV reflex, they're not really candidate for venous ablation because that's what the insurances tell us. But the jury trial, which was a multi-center study, showed that a junctional reflex does not change symptomatology or outcomes of ablation in patients with GFV reflux. So this is really hopefully will change the old paradigm of treatment. And I think this was a platform where this data was highlighted. In terms of technology, I think when we tried for this session wasn't only talking about like, oh, how many devices are out there, because you can spend hours talking about there's a new device on the market every day, but really to understand, who needs the procedure. You can pick all kinds of devices, but who needs this procedure? And I think this was well highlighted in the VTE talk, because it was talking about how the whole field moved from thrombus, extraction. We used to just dissolve with thrombus dissolution theory, but now we're really, doing more thrombus extraction. And there's a multiple mechanical thrombectomy platforms. But that was not the point. The key point was that you need to decide what the patient needs, right? And then look at the clot burden and chronicity and anatomy and what are the patient goals are before choosing the intervention. But the device itself is probably not the key thing, but mostly understanding how to really pick the right treatment. And I think the whole theme of the session was like, what tool do you use for which patient and based on what evidence? And is really what, I think what I learned from this session is really not picking like, oh, well, this device is good for, as in looking at the whole picture. So I think there were so many useful points that, I think the upper extremity DVT guideline update was a key because we get consults about upper extremity DVTs on a daily basis, right? And I remember starting practice and I was like, okay, well, we'll anticoagulate this patient, or maybe this patient we don't. We'll pull the catheter for this patient. We never had a clear idea what to do. And I think this effort of American Venous Forum putting together these guidelines was really helpful because we now have an organized thought treatment algorithm. And the most useful point of this guideline, the way it was organized very nicely, was the etiology. This is the first decision that determines the rest of the management pathway. And now it helps me think that way because I never really had this organized thought about upper extremity DVT before I heard this. You first think about etiology. Is it thoracic outlet obstruction, or is it a catheter associated DVT, or is it a non-catheter associated DVT? And then it becomes more clear what to do next. So I think those are kind of some of the takeaway points that I learned from this session.
You also had some talks on the upcoming guidelines for venous leg ulcers and for lymphedema, which is also something that we see quite commonly. No matter where you are and what part of the country you are, you see these patients every day. It seems to be even more so nowadays. Can you talk a little bit about those upcoming guidelines? Because it sounds like those are going to be quite important.
Yeah, I mean, I think those are going to be key. And again, I think, this whole session was put together in conjunction, in collaboration with American Venous Forum. And it's highlighted how, like, when organizations, what they can do and push forward guidelines and help us put together evidence and kind of learn. And because I think on an individual basis, you can never obviously review all the evidence. And then Dr. Rapala gave a talk about the upcoming venous leg ulcers, and she really concentrated on how the guidelines are being modernized and what evidence they used. And it was shocking to hear how many thousands of papers they reviewed to really put a strong guidelines. And I think it's really important not only to understand what to do when you read guidelines, but also understand how strong the evidence is. So she really highlighted how robust this process is right now, and to set up the guidelines, which really makes me think that the outcomes will be great. Because when you read the guidelines, you want to know, are you actually, how reliable this evidence is? Are you going to change your practice on these new guidelines? And the lymphedema guidelines, well, I think it reminded me personally that lymphedema is still part of vascular care. I think we often forget. I think it was described as forgotten third component of vascular system. It's sort of this chronic, under-recognized, undertreated. Nobody wants to take care of it. But it really brought us back to say, hey, we vascular surgeons should really be in the forefront of managing these patients. And I think the guidelines will help us do so. A lot of times, lymphedema patients have chronic VI. And we should be managing all patients with chronic VI and knowing how to also manage lymphedema because it often coexists with chronic VI is the key. So it really kind of reminded us not to forget about this component of vascular disease.
I agree with you. I think the venous leg ulcer and the lymphedema papers have set new standards for how these guidelines need to be set up. They really heightened the bar and made it improved, I think, the rigor of the guideline process. But more importantly, I want to thank you for packing this all in 90 minutes. It sounds like it was really quite a whirlwind tour, a really high impact, really useful, clinically relevant papers that are structured in a well-defined manner that are things that we see every day, patients that we see in our offices, in our clinics. on the inpatient side. So thank you very much for putting all of this together, and thank you for summarizing it for the VLU podcast.
Yes, thank you.